This conference will now be recorded.
Hello, everyone. This is the This is the AnCan's High Risk Advanced and Metastatic Support Education and Discussion Group for the 28th November 2023. We're going to start by thanking some of the sponsors that help us pay the bills without requiring us to push their products or in any way influencing what we talk about or what we say. And hopefully this list is up to date because there's been a number of recent changes as Rick works with these guys. But what I've got is Bayer and Pfizer, Myriad, Myovant, Janssen J&J, Telix, Foundation Medicine, and maybe Blue Earth. Yes, Rick?
Yes.
Yes, okay. We have one newcomer tonight. Now, a couple of people have just showed up while I was talking. Let's see, Kurt is here. Kurt, do you want to bring up anything tonight?
No, I don't.
Okay. And hi, Paul.
Hi.
Want to bring up anything tonight, Paul?
For me?
Frida?
No.
Okay. Okay. So I would like to introduce Stephen Friedman to the group. That's him with the hat. Stephen is from Tucson. And how old are you, Stephen?
Well, I'll be 74 on Christmas this coming month,
Christmas Day?
Christmas Day.
Oh, I'm surprised they didn't name you something like Noel or something like that.
I'm grateful that that's not my name.
What year were you first diagnosed, Stephen?
I was just diagnosed in the last maybe 4 to 6 weeks.
Where? In Tucson?
Tucson.
Okay.
Yeah.
And who were you working with at that point? Who made the diagnosis?
Dr. Jenny Myers.
Is that a urologist?
She's a urologist. Yes.
Okay. And how did that happen? Did you have an abnormal exam or an abnormal Gleason
Yeah, I
score?
had my GP, who was a new GP to me, recommended I get a PSA. I had never had a PSA before, and it came in shockingly high, 65.8.
You can't shock us, by the way.
Oh, okay.
Not this group.
Yeah, I understand the context.
64 doesn't shock this group.
Okay, great. Normally I like to get high grades, but not in this situation.
No.
So
So you got
we
a
did
64 and you
yeah,
got referred to Dr. Myers.
that's correct. And then we did a subsequent one to verify, and the second one came in at 62.8, something like that.
Yeah.
So we, just to briefly elaborate, we did an MRI. Well, I'll let you ask the questions. I won't get ahead of myself.
Okay. Well, let me just ask you about your scans then. You had an MRI and maybe some other scans. So tell us about all your scans so far.
Okay. So I'm going to go to my notes here. My MRI, it's probably about at least a month ago. It came in PIRADS 5, and there was a 3 centimeter lesion with broad-based contact.
Wait, I don't understand what you mean by a 3-7.
3 centimeter.
Oh, 3 centimeter. Okay. Yeah.
Yeah, about 1.2 inches.
Yeah.
And it had broad-based contact with the overlying capsule,
Okay.
but there was no overt extraprostatic extension of the tumor.
Okay.
The bladder walls were thickened. There was BPH throughout the transitional zone, and well, I think that's enough because we did a subsequent biopsy, and I can give you that information.
So that was the only scan you've had so far?
Yes, I'm scheduled to get a
Okay.
bone scan on December 7th,
Okay.
and Dr. Myers sent. We did a biopsy a couple weeks ago, maybe 3 weeks now, and I will read you the results of that. And she's sending the tissue out to get a decipher test.
Okay.
And the anatomic pathology report briefly had a Gleason score of 7, 3+4, with a grade group of 2. I was actually somewhat relieved that it wasn't 4+3. There were 4 cores with cancer.
4 out of
There
4
were
out of 12. Or how many?
they did the cores examined were 13, and
Hold on just a second, Steve. Rick wants to get our attention. What's up, Rick?
Is this gentleman in the right group, John?
Don't know yet.
I think I suspect I do if he's had no other scans and he's a 3+4.
Yeah. Good.
I think the thinking was that based on the PSA score, they consider it high risk. But of course, I'm guessing here. In any case, I'm very clear that that's their assessment. I saw a radiology oncologist today to get her view on treatment. And of course, I saw a follow-up after the biopsy with Dr. Myers, and she explained the surgical procedure. And
Let me describe what Rick's question is all about. AnCan has a whole bunch of different groups for prostate cancer patients, some with very mild disease that's very unlikely to metastasize or advance, all the way to this group, which is the advanced metastatic group. There's an intermediate group behind us that we were referring to earlier. And so Rick was wondering whether you with a Gleason of 7, you don't get you get considered to be a very high risk person with a Gleason of 9 and 10, and you get to be a high risk group with a Gleason of 7 if it's 4 plus 3 and 8, and you're probably might be considered in the intermediate risk group. You come to this group if you have metastases, which so far we don't really know, although your MRI didn't pick up any
that's correct.
metastases in the
That's
lymph nodes,
correct.
although mine didn't either, and I had metastases in the lymph node, so you might not know until your surgery if you do have surgery. So as far as we know at this point, although your full workup isn't completed, you're not metastatic or advanced, but you do have, like you say, quite a high Gleason score. So Rick is our boss. He's the one of the founders of AnCan. He's the one that set up the whole structure that we're working under and sent us all thank you notes on Thanksgiving to make us feel good. So this is his structure, and let's see what he says we should do right at this point. Okay, Steve. Whatever is decided, you're welcome to sit in here. Uh, sometimes we don't. Sometimes we don't like the guys with less risky disease to sit in here just because it might scare them, you know. But let me turn it over to Rick for a minute for a judgment. Rick, that was an
You're muted, Rick.
introduction.
Technically, you are high risk, so you chose the right group. But the concern that we have right now is that if you are in fact a 3+4, even though your Gleason is 65, your Gleason is 3+4 and your PSA is 65, you could really respond very well. And normally we bring high risk people in here if it looks like they're going to be faced with hormone therapy. In your case, you may not even be faced with hormone therapy. That's going to be a call probably of the radiation oncologist, because I think we can't give you medical advice, but I think best practices indicate that at your age, surgery is not a good option. Doesn't stop you deciding that's what you want, but we would be guiding you to heavily question any urologist that wanted to cut a man who's 74 years old. It happens on rare occasions. We've seen it recently, but it's not recommended by the AUA and others. So I think you're probably better off working in the low intermediate group. But I also think there's a couple of things you need to be pushing your doctor to do, given the PSA of 62 to 65. And one of them for sure, if they haven't already done it, is a PSMA scan. Have you had a PSMA scan?
I inquired about that, and she said that I probably don't qualify for that at this point.
Well, I think she's wrong, because I think that if she with a PSA of 65, I think that would justify them considering you. If you were 4+3, you definitely would be considered. But as a 3+4, which is a good thing, to rule out that there's any metastasis, which is the concern with a PSA of 65 with such a small amount of cancer, because you don't have very much cancer in there. I think a good urologist should be willing to go, and I think you should tell her you want it. If it were me, I'm sorry, I shouldn't say you should. I should say if it were me, I would be leaning on her very heavily to say, I want a PSMA scan because I am high risk. And PSMA scans before treatment for high risk men is approved. And she should know that. She should know that.
Okay.
Where is she? With Arizona Urology? Are you with
Yes.
Arizona?
Yes.
Yeah.
Yeah.
I think you should push for that. Who's your new PCP?
PCPs. What does that refer to?
GP. Who's your new GP?
Oh, Dr. Michael Locali.
I don't know him.
Are you must be in Tucson.
I'm in Tubac.
Too bad.
So, I just think that I would, if it were me, and we'll open it up quickly for the guys, but I don't want you to have to sit through listening to guys who are much further along, and we're talking about chemotherapy, because this isn't, you might not even have to go there. You might not even have to go to hormone therapy. And if you did go to hormone therapy right now, probably most docs wouldn't give you more than 4 months. If you are, have you had your biopsy slides reread? Do you have a second opinion on your biopsy slides?
I have not gotten a second opinion, and I know that Dr. Epstein had been recommended, but that he's somehow had to step aside from his official position for some reason.
Right. So Dr. Epstein's on a leave of absence because they're investigating some alleged charges. He is on our advisory board. We would say either send it to his lab, or the other very good alternative is to send it to Tufts, to Dr. Zhou, Shou, who knows us well. Somebody just told me yesterday that he sent his slides, told us in the low intermediate group that the slides got sent to Zhou, and Zhou called them up personally and discussed it for 20 minutes. So, he comes from the Epstein school. He was trained by Epstein. So we would, but, definitely given the PSA and the, I think I would want a clear opinion on that. And when they did the biopsy, did they, they did it based on the MRI? They did a fusion biopsy?
It was a fusion guided biopsy. There was one other finding that I didn't mention. There was atypical glands in one other area in the left base, which my radiologist said today was, a precursor of cancer.
Okay, but they didn't find anything like cribriform or, and you're saying that everything was contained in the gland. I thought I saw Peter. I thought I saw Peter Kafka was, yeah, Peter, do you want to, would you like to just talk for a couple of minutes? This is really more your area than it is mine.
Yeah, I think he should be. I mean, he's still in the information gathering stage. He doesn't have his decipher results back yet. I think he should come to the next low and intermediate, and we're trying to figure out when to do that because the next one falls on your next one falls on your birthday on Christmas Day, and we're thinking of moving it to a different day before that or right after. So make sure we have your email and perhaps phone number, and we'll contact you. And I think right now you might be in this group, but I think right now it's probably not the time, is my guess.
Okay. Let me inject one other piece of information. When I saw the radiology oncologist today, she said that the protocol, if I elected to do radiation, it would be photon radiation, external beam, and that they would put me on hormone therapy for 2 years, beginning prior to the radiation, and that the radiation would be for 5 days a week for 9 weeks.
Okay, so let me jump in here. Who was the radiation? Who was the radonc that you saw?
Dr. Shelley Hanks.
Yeah, where is she? Is she at Banner or is she somewhere else?
No, she's with Arizona Urology. Her office is next door to Dr. Myers.
Yeah, I think she's we would say she's probably off base. She's telling you, the reason she's telling you 2 years is because of the PSA being 65. And I think that's a very dubious reason to do 2 years. If you were 4+4 or 4+5 or 5+4 or 5+5, yes, 2 years, very much so. I did that. That number one. Number two, when you're in that high risk category, there needs to be, you really need to dig in a little deeper, as Peter said. We don't have enough information. There's a couple of things you need. You need a second opinion for absolute certain, number one. The second thing you absolutely need, in my view, is a PSMA scan. Because if we were to see something outside and we can't rule that out, then yes, maybe we've got a different situation. Third thing is, nobody should have to do 9 weeks anymore. She just doesn't have the right equipment. She should be, in your case, either they're going to radiate just the gland, which means they can do that in 4 or 5 sessions with stereotactic body radiation. And she probably doesn't have that, so she doesn't discuss it with you. Or they're going to do maybe 20 sessions across your pelvic girdle, plus another 4 or 5 sessions to the gland, which is maybe 25. So you're dealing with someone who doesn't have the right equipment, and we would question on what basis she thinks you need the 2 years. You definitely need a second opinion. I'm trying to remember the name of the lady. No, I don't have my Tucson guy on here. I'm trying to remember the name of the lady at Banner. There's a radiation oncologist at Banner. Or you can go back to this lady and say, well, what about SBRT to the gland? And where else were you planning on radiating? Peter, do you want to comment on that? I know Jim Marshall's very anxious to say something, but Peter, would you want to comment on that?
Again, I think we should talk to this guy offline. I don't think he's ready for this. I mean, it's a lot of time. I think he needs to get a lot more information before we can really help. I mean, we can help guide him to get a second opinion and stuff, but I don't know if this is the time to do that right now. Right? Can we get your email, Stephen? Can you put it in the chat window?
Yeah, when I signed in, I presented it, but I could put it in the chat window.
Do that. We'll contact you and help you out.
Okay. Where is the chat window?
Look in the upper right of your screen, and there are something like a line of 5 different little icons.
I see it. I got it.
And you can send it to one of us privately if you don't want to put it in publicly.
Yeah.
I don't. Yeah, I just sent it.
I think that the extra information will really help, because you have to decide now whether to have a more conservative or a more aggressive treatment plan. And for the rest of us, when we were in that situation, we basically had to play the odds. But if you can get one of these PET scans, you may not have to play the odds. You may come up with an answer of whether you're metastatic or not at this nice early stage, and set which track you're going to be on.
Doesn't the bone scan do some of that?
No, not really. The bone scan is actually getting to be somewhat old-fashioned way of finding out if there's a hot metastatic lesion in the bone, which prostate likes to metastasize to, which is actively metabolizing and gets picked up on the bone scan. But if you can, but the PET scan can not only see lesions in the bone, but all the soft tissues as well. So, for instance, let's say you had a hidden lymph node that's carrying prostate cancer, or a couple of them. You wouldn't find that on the bone scan. you might proceed thinking you're not metastatic when you are. And so it would be really nice if they would give you a PET scan, a second read on your slides, and a second opinion on your radiation oncology.
And you know, the irony is that if they consider that you are eligible for a bone scan, that automatically means you're eligible for a PSMA scan, because the people they usually give bone scans to are the same people they should be giving PSMA scans to. If she thought that you weren't eligible for the PSMA scan, you wouldn't be eligible for the bone scan either.
Wow. Well, this is obviously information that she didn't impart to me because I asked her specifically about a PSMA.
Well, you know, the problem is they don't want to get into it because they may have to work a little bit harder. They feel they can get the bone scan or a CT scan approved, but for a bone scan or a CT scan, you've got to be high risk, and they usually only do it for 4+4, and occasionally for 4+3 they'll do it, but they don't do, as a matter of course, they don't do a bone scan for 3+4s. Isn't that right, Peter? Oh, Peter's not there. He must have stepped away, but I'm pretty certain that as a matter of course, they don't do bone scans for 3+4s. Now, if you're a 3+4 and a 60, they might do, but then if you're a 3+4 and a 60, they should also be doing a PSMA scan.
Okay.
Because if they think they're looking for metastasis, which they are, they need to look for metastasis with the best possible equipment and the best possible scans.
Right. And why do you not recommend surgery for someone my age?
I don't want to get, again, as Peter says, this isn't the right group to talk about that, and it's not fair on the other guys in the group. But we're very, very happy to discuss that with you, and we will. Jim Marshall, you wanted to say something?
Yes, anyway, I thought I heard he said he had a grade group 2. Does that sound right?
3+4 is grade group 2, isn't it?
Yes.
It was more specifically, it was a 2C because I had lesions in both sides of the prostate.
Okay.
Oh, he's talking about staging.
So 2C but he's a grade group 2, 3+4, and a 2C, because he was on both sides of the prostate. But I think what you said is there was one 3-centimeter lesion. It must have gone across from left to right.
No, it was a 3-centimeter lesion.
Yeah.
I said 1.2 inches.
Okay, 3-centimeter lesion left to right. Anyway, I don't. This isn't the right group to be discussing it. Unfortunately we had a group last night, and so you just missed it. However, we will have another group this month. We've just got to decide when.
Okay. Well, obviously, I maybe I shouldn't, but I do feel rushed to start some kind of treatment because this has probably been going on for a long time undetected.
You don't
Stephen,
have to feel.
Stephen,
Yeah.
my email is Peter K. Write it down.
I'll put it in the chat.
Peter K at AnCan.org. I will contact you and we'll discuss this offline, okay?
Okay. One more time, Peter K at ancam.org. O-R-G.
AnCan.org.
Got it.
And
Peter.
Stephen, I don't think you have to feel rushed.
Okay. Okay. I am symptomatic, so that's problematic too.
Oh yes, that you should be able to parlay that into a little more aggressive workup then.
Okay.
What is it, pain or obstruction
No,
or
no,
what?
no pain, just urination problems.
Well, you have
basically-
BPH also, though.
Pardon me?
You have benign prostatic hyperplasia as
Yeah,
well, right?
Yeah.
Yeah, because when you're asking for things like PET scans that they're hesitant to give you, play the PSA card, play the symptomatic card, and try to get yourself into a category where you can get some better diagnostic information. And when you get your Decipher score, discuss it with Peter.
Okay, thank you so much.
Very nice to meet you.
Okay. Uh, should I sign off or is it okay to
Well,
stay?
I think as far as I'm concerned, I think you could stay and listen. You might hear a lot of stuff that's not applicable to you. If you find yourself getting alarmed about it, then hang up and talk to Peter about it later. Is that
Okay.
okay with you, Rick, that he sits in?
Oh, I mean, you're more than welcome to stay. We just don't want to alarm you. That's why we separate the groups.
Okay. Well, I think I will say goodbye to everyone, and I thank you so much for
Stephen,
the.
hold on a minute. I put a link to a genetic test. You really should get genetic testing. It's free. If you look in the chat window, it's the prostate cancer promise. You should do that because your name. I know other people named Friedman. They're all Jewish, and if you're Ashkenazi, you might have BRCA. I have BRCA too, and it definitely has an effect on your long-term results. By the way, when I first had my biopsies, I had a couple of them, and they were all 3.4. But when I had surgery, it was 4.3. So you never know. But
That's right.
you really should get that genetic test. Look in the chat window. You can click on that. Do not pick the option to have your doctor involved. Otherwise, they won't send you the spit tube. You just want to go through and they'll send you a spit tube. You spit into it, and they get a geneticist will call you about and help you understand what the results are.
Okay, I'm looking for your message in the chat. Would it
It's a
be at the
big
top or the
green.
bottom?
It's right above your email address, and if you click on that, it will open the window for you. And it's a good suggestion on Jeff's part. I mean, we really didn't get into the detail with you, but it is another test you should do.
Okay, this is from Jeff.
Marchie,
Yeah,
just click on
Mark
that. Just
Murphy.
click on that link, Stephen,
Got it.
and it will
Okay,
open a window for you.
got it.
I'm going to
Thank you
head
so
down
much.
my list. Oh, you're welcome. Glad to meet you. I'm going to head down my list now, which starts with Joel Blanchett. I'm looking for his picture. It moved. Oh, there you are. Joel, what do you got on your mind tonight?
Okay, two quick things. About 4 or 5 weeks ago, we discussed whether or not the SUV max was the same with FDG PET scans and the PSMA PET scan. I discussed this with Dr. E when we had a televisit about 3 weeks ago, and she says, no, they're definitely not the same. One has nothing to do with the other. So that's her explanation. Number two, I just finished my 5 treatments of SBRT to my T6 and T9 vertebrae yesterday. I'm starting with the lumbar spine in December from 18 to 28 December. And that's it. That's the update for me.
So regarding your first point, the warning is don't compare apples and oranges, right?
Correct.
Okay.
And what were the two things again, Joel? One was the SUV, and what's the other thing that you asked
They're,
about?
they're both SUVs. The SUV and the FDG PET, mine as example was 4.2, and my highest SUV in the PSMA PET DCFPYL was 14. So anything above 10 is definitely cancer. And I was trying to compare it to the FDG PET that I took, and the doctor says there's nothing to do with each
Okay,
other.
so in other words, don't compare SUVs between different types of scans.
Correct.
Okay, good point. Thank you.
Jim Ward, what did you want to bring up?
Yeah, hey guys. Um, this is going to be a little like deja vu. If you all heard Len share his story, I'm going to guess about a month or so ago, with respect to getting a bone strengthening agent infusion. I got one yesterday, reclassed, and that was intended to lock in um, the gains that I've had with Prolia over the last couple of years or so. And they warned me that I might feel a little achy, kind of like a flu-like symptoms. So I was prepared for that, but like Len, in the middle of the night, I woke up with chills and I was shaking like a leaf. Um, and I felt pretty good for most of the day. I'd say just before I went to bed, I started to feel a little bit achy, but I didn't give it much concern because they'd already talked about how that seemed um, likely. But all I can say is, Prolia never gave me any trouble. Now, granted, that was an injection, just a shot. This was an infusion, a drip infusion. I'm just, I don't know if people are as dialed into how significant these side effects can be. I mean, frankly, guys, I feel like crap. And I was on the call pretty early, and John, just looking at me, recognized that. I feel like I've got the flu, and I'm just lethargic and achy, and I still have a little bit of chills. So I don't know if anybody wants to comment on this, but I definitely wanted to put it out there that, if you're a candidate for the reclass with the zoledronic acid, that know what you're getting into, because now, granted, not everyone's going to have the kind of reaction that I had and that Len had, but man, in the middle of the night, I think I would have been freaking out if I hadn't heard about Len's experience. As it turns out, I just sort of said, okay, I'm having a Len experience, and I layered up, and after about an hour, I think I was able to kind of tamp down the chills and the shaking. But man, it's nothing to mess around with, guys.
Len,
Yeah, I'm just looking in the chat, and I see that David Muslin, apparently his wife had the same response, because, when women come off Prolia, they do the same thing. They give them a shot, an infusion of Zometa, or as Jim got, what was yours, Jim? Reclassed. Yeah, it's the same,
Reclassed.
basically the same drug. They're both zoledronic acid. So maybe this is a lot more prevalent than we've been told as a side effect.
They said to drink a bunch of water after the infusion, which I drink a lot of water all day long, and so they said that would help flush it out of your system. But boy, I don't think any amount of water was going to probably prevent what I went through. And like I said, I got the infusion at roughly 2 o'clock yesterday, and I still feel like crap. I may not even stick it out for the duration of this call, because I feel like I probably should just kind of go to bed. But I did want to share this experience with people, because it's not that uncommon that guys in this group are potentially going to get reclassed or some other bone strengthening agent to kind of lock in the gains that they've had.
any other possible preventative measures besides drinking water which didn't work? David or Len or anybody hear of anything?
No, I haven't heard of anything, but I did want to add, sorry to have to add this, Jim, but I did feel pretty crappy for the next several days. I didn't have any
Ugh.
more, I didn't have any more shakes, but I did feel like kind of low grade fevers, for a few days afterwards.
Yep, that's exactly what I've got. That and just kind of achy, kind of
Yeah.
muscle, kind of skeletal aching. But yeah, I got a low grade fever for sure. So
Yeah, just take it easy, rest. Don't try and exercise your way out of it.
oh God, no. As much as I enjoy exercise. the last
Yeah.
thing on my mind.
So the one thing I wanted to mention is that, back in the day, they used to tell you when you were getting Zometa that some people might have a flu-like response. But I think probably in all the support groups, we only heard it a couple of times until Len brought it up. And now we hear it happens twice when the gents have been on denosumab, and then they've tried to lock it in with zoledronic acid. And I am wondering, and I don't know how we would figure this out, but maybe the Brains Trust has some ideas here. But I'm wondering, could there be an interaction between denosumab and zoledronic acid to make it more likely that the zoledronic acid is going to result in flu-like symptoms?
Yeah, I thought about that too, Rick. Maybe we should go to the drug interaction website and see if there's any interaction there. Although I actually,
I'll check it now.
oh yeah, okay. I was getting denosumab every 3 months, Xgeva, and it was actually about an extra fourth month before I actually got the Zometa infusion. So I would assume the good part of that denosumab was already through my system. But yeah, it's definitely a possibility.
Yeah, good
No
point there, Len. And I'll
interaction
just
found. I'm sorry if I interrupted anyone. No interactions
no,
found in my checker.
Okay.
yeah. What I was going to say, just to add this as a data point, I was getting the Prolia every 6 months, and my last Prolia injection was in April, and so we're at 6-7 months out from that last one with the reclass. So it's kind of a similar situation where you would think that the Prolia would have kind of washed out or worked its way out of my system. So, but I still think there could be something to Rick's theory. How can we possibly rule it out?
What about reporting this? Any any ideas? Should we
Oh, yeah.
have Jim report it?
Yeah, I'd be happy to do
There's a
that.
form you can fill out online and report a drug, whether it's either an interaction or an adverse effect. Well, I guess we don't know for sure.
Would this be submitted to FDA?
Yeah.
Yeah, or the drug company,
Yeah.
who then will do that.
You can look on the reminder, Jim, and the website to report adverse. I linked it on the reminder at the bottom in that box. And it's also it's linked in a bunch of different places on the website, but the easiest place to find it is just go to the reminder, because it's now on every reminder, and that gives you the website where you to report adverse
Okay.
incidents.
Well, I'll do it, guys, and I'll let you know what, if anything, I hear back.
Thanks.
I'll do it too.
Thanks, Len. Be sure to, when you report, be sure to point out that these were to lock in gains from denosumab.
Right.
Right. Will do.
Okay, good to know.
Thanks,
I'm going to
guys.
move on. Peter, you're the next guy on my list.
Okay, mine will be quick. So the last whenever it was, 2 weeks ago, I mentioned that I was having reactions for prednisone withdrawal, and I brought up the fact that it made my testosterone plummet, which surprised me. I'd never thought that was a side effect from prednisone withdrawal. But now I'm past it. This past weekend, I seem to have come out of it. I did a blood test yesterday, and my testosterone jumped up 40 points. and my appetite is back, and my intestinal issues have disappeared. And best news of all, my PSA stayed right around where it was a month ago. So
Yeah.
hallelujah. I was thinking maybe I'd get 6 months out of the Keytruda thing. Now I'm shooting for the moon. I'm hoping I'll get a year out of it. I don't know. Maybe it's the miracle for me. Maybe it's the Christmas miracle for me. I don't know. But I meet with my local oncologist for the last time tomorrow, and that'll be one of our conversation pieces. So I don't know where I'm going, but I'm a happy camper.
So what were the numbers, Peter? Where's your where's your testosterone right now?
It went from 36 a month ago up to 76. So it's getting close to the range where it was a few months ago.
And your PSA is where?
PSA is 78. It was 0.78. It was 0.73 a month ago.
Got it. Yeah, that can, yeah. Okay, well, we're delighted to hear, that the prednisone just took a little longer to wear off.
Right. Yeah, and I've been in touch with Dr. Bob, and unfortunately, the Keytruda went the other way with him. So it's not a miracle drug, and you got to meet. I guess I somehow fall in the sweet spot, but there's not many of us that have done it. So I'm hoping this is again my Christmas miracle.
How many doses did Dr. Bob get, Peter?
I don't know. He was taking a double dose every 6 weeks. I don't remember where he was. Maybe 4, something like that. I'm not sure.
But he never had a response.
His PSA just kept climbing. And still does.
Yeah, it's too bad.
How many doses did you get, Peter?
12. We cut it. I was going to do 13, but we cut it off because the side effects were just getting too intolerable. Loss of appetite, loss of weight. That's what drove me to. I went on prednisone instead, and that's why I was having problems getting off of it. So
Gaining so much experience, over the years about things like watching out for prednisone tapers and interaction with testosterone levels, and the last couple of things we were talking about, things that we really don't get warned about, and some of which are not even in the literature. It's really
Right.
kind of great, the experience that we're gaining here over time.
Yeah, my reminder notice for my meeting, low and intermediate meeting yesterday was that we're all like an N of one in our own trials. I mean, just the
Yeah,
conversation a minute ago about denosumab and so forth. I mean, we're all kind of unique people, and we've got a wealth of experience to pass on. That's the great value of this group. Many of us will probably never experience some of this stuff, but we've got a lot of stuff that our doctors have never even heard of.
yeah. That was a good write-up, by the way. I liked it. Is that it, Peter?
That's it.
Any other comments or questions about that? Anybody right now on a prednisone taper? Okay. Okay, moving on to Frank.
I got some great news before Thanksgiving. I had a MRI of the abdomen and a CT scan of the lungs, and this was 8 weeks after my previous CT scan, and that showed that my tumors in the lungs, the nodules in the lungs were growing, and my PSA was continuing to rise. Well, on this latest scan, the PSA remained at 0.33, did not rise, and the 4 nodules in the lungs stayed the same size. They didn't increase. So as a result, I jointly agreed with my doc to hold off on a PSMA scan to see if what the nodules were going to do and the PSA was going to do, since everything evened out. And he's keeping me on abiraterone and prednisone. I'm now on it 12 weeks. So that was good news to hear, because we both expected that the nodules were going to continue to grow and the PSA was going to continue to increase. I'll be seeing him on follow-up in the beginning of January.
Will you get another CT scan in 3 months?
He wanted to hold off based upon my PSA in January. But
Okay.
if it stays firm, then he'll probably hold off for another month or two. If it increases, he'll probably move forward with the scan, and also the PSMA scan.
Well, you joined the number of members with good news today. Rick, were you going to say something?
Yeah, I'm assuming that you never did then the spot radiation, and you never went forward with the PARP inhibitor. Is that right?
No, that isn't the case yet, because the abiraterone seems to be working along with the Orgovyx. He changed
Okay.
me to the abiraterone from darolutamide back 12 weeks ago, and he wanted me on it at least six weeks, and now it's been 12 weeks, and it seems to be effective at this time.
Okay. Okay. That's good news.
Yes, it was very good news for Thanksgiving.
Comments, questions, anything? Okay, I'm going to move on to Todd.
Hello.
Hello.
Hello, hello.
Hello, hello.
What's on your mind, Todd?
Update today. I met with Dr. Guancho. I don't know how far back you want me to go, but I met with Dr. Guancho. She concurred with MD Anderson, Dr. Hahn, to go on a holiday, even though it's only been 7 months on ADT. So that's really my update. I know that there's controversy about that. I know that 6 and 7 months, and I'm a Gleason 9, so there's that. But I just do not like the side effects at all, and I want to try to, get away from it.
When you first brought this up, there were a number of us that were skeptical. So it's funny now we're skeptical about going off ADT, and the doctors are encouraging it. A few years ago, it was kind of the other way around. Well, what is going to be done to monitor you in the meantime? Quarterly PSAs or what?
So Dr. Hahn wants me to do blood work a month and a half from now. I just stopped on ADT yesterday, so this is my second day off of it. And
Which ADT was it? I forgot. I'm sorry.
Zytiga. So it is 250 of Zytiga, 120 of Relugolox, and 5 of prednisone, 5 milligrams of
Thank you.
prednisone.
Okay, thank you.
And Dr. Guancho said she wants me to do blood work, and go see her in 3 months.
3 months.
And go see her in 3 months. 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 3 months And both doctors are understanding that I'm off of University of Chicago for reasons stated earlier, and so I feel great about it. I mean, I think it's the right thing to do for me. I know it's unique to each individual, but for me, it feels like the right thing to do.
And Todd, what did she say about the fenbendazole?
She said that she had had other patients that had gone down that path and that she had not witnessed any positive end result. She asked if I was going to continue on it because I gave her a list of what I'm taking right now. And she asked if I was going to continue going, on it. And I said, yes, I'm planning on doing that. And that was kind of the end of it. But I really don't see it as something that the medical industry would acknowledge in any kind of a positive way because it's not consistent with their MO.
So
Okay, did she tell you how many patients of hers were taking it and without a good outcome?
She said two, and she said that they both had they were not what I have. They were different cancers, and I can't remember what the cancers were, but there was two. So
okay, so you're going to continue.
Yeah. Well,
Yeah.
there's no side effects. So there's no side
Right.
effects, and there's no real cost to it. So I mean, there is that. It's like it's not really like a risk to continue on with that from
Right.
where I sit.
And it's really the only way you'll know if it's effective now that you've stopped the other meds.
Right. Right.
So I
Yeah.
think you're doing the right thing.
I feel like I am. I mean, I know that there's so many different paths that you can go down, and but I also know that I have to be my own advocate. And although I'm not as smart as a lot of folks about this stuff, um, from what I've researched and tried to figure out, this is the right thing for me.
Yeah. So I'm curious on a couple of things, Todd. First of all, what did she say about the D'Amico editorial that I sent you? And I sent it to the Brains Trust too, so they saw it, and it'll be in next week's reminder,
So
guys. So
I printed out that report and I brought it to my meeting today, and because of the conversation that we had, it didn't feel appropriate to bring it to her because she was very accepting. Believe it or not, Rick, she was very accepting of me going off of it after only 7 months. So
well, you see, the problem I see is this, and I don't mean this personally, Todd, but when a patient goes in, and we've had so many of these patients go in, and they advocate for themselves that they don't want to be on it. There are a lot of doctors who say, okay, I'd rather he stayed on it, but he's coming on strong. And so they're biased. And that's why, if it would have been me, I would have presented this paper to her and said, look, this is what Dr. Hong says. I'm not going to tell you what I think as the patient, but read this. What do you think? When you walk in there and you say, I really can't, I'm having trouble with this and I really want to get off of it, and this is what Dr. Hong says, it's easy for her to say, okay, I agree with Dr. Hong. And why I sent it to you was because I really felt that if she looked at that, we'd get an independent opinion, but we don't have it. Look, the paper will go out to everybody. And maybe we'll talk about it. But in a nutshell, D'Amico wrote an editorial that was published in GU ASCO last February. I'm a little late, but they sent a hard copy and I read it and I thought it was a good editorial. Basically, what they said is that the amount of time you spend on hormone therapy is very much individualized with follow-up radiation. But the big guidance is, what was your Gleason score? There are other factors too, but what was your final Gleason score? And for those people who have lower Gleason scores, like a 4+3 or less, which I guess would be a grade group 3 or less, 6 months, 0 to 6 months is probably the right number. For those who have a higher Gleason score after surgery, namely 4+4 or higher, grade group 4, grade group 5, they should go somewhere between 6 and 24 months. And I think it's a good guide. But I'm not just with you, Todd, but I'm really, I've been thinking about this a lot, that there's a difference between advocating for yourself for what you want and advocating for yourself for what is best for you.
So
And
here's the way I see it, Rick. So
yeah,
basically, obviously, the ADT, my body was very receptive to it. It worked extremely well, and the likelihood is that if I need to do it again in the future, which I likely will, it will respond well at that time. In the meantime, to do it any longer than I have to, my body is going to find ways to work against it, which is the way that the body works, and I have a plan B that's going on at the same time, which is basically zero or low risk of the fenbendazole. And I'm not saying that I'm counting on the fenbendazole. Let's say that the
right,
fenbendazole was off the table.
right.
If it was off the table, it's still the same conversation. And this is what I talked to her about today. Was basically
Well,
if in 6 months or a year or 2 years or 3 years my PSA starts to go up, she said I wouldn't do anything drastic. I would wait till it went up to 7, which is where you were back then, and then I would go back on the ADT. And I said, okay, so what's the downside of doing that? And she said, well, there's no downside of it's fine, totally fine to do that approach. So that's with fenbendazole off the table. I mean, what's wrong with that? Let's say that fenbendazole was not part of this.
well, here's what I see, okay, and just from my experience. Empirically, I'm looking at the results of this of this trial that was cited in the Amico article. It's just got the name of the trial's just gone out of my mind. I'll get it because I know Len's. Len, did you read the article? Did you read the Amico paper yet? Or Babcock, did you read that Amico paper yet?
I don't believe I don't believe I did, Rick.
Okay. So hold on a minute, and I'll tell you what the trial is, because it's gonna be relevant, and I just have to pull it up. Amico. Waiting for PSA. I don't find it now. Of course, I don't find it. All right, I'll find it in a minute. But the measure was metastatic free survival. So what you want to do is you want to go as far as you can without seeing any metastasis. And what bothers me is that if you stop at 6 months and you're coming from a 4+5, which is you were 4+5, right? Or 4+4?
4+5.
4+5. And you're coming from a 4+5. By the time we see it again or something happens, there's metastasis. Now, once there's metastasis at that point, it's a slippery slope. I think of a very dear friend of mine who doesn't come into this group, but listens to the meetings, and he'll know who I'm talking about. And like you, he had some difficulty tolerating it, and he had a very, very high corner office type job with a Fortune 500 company. And he decided to come off of it early. And now his situation was a little different to yours. He didn't have surgery. He did 2 types of radiation and should have done 24 months, but he only did 6 months. And what happened is he came off early, it came back, and the next thing he had to do was chemo. And I always think, well, if you could have stuck it out, which in my case, that's what I did, I'd never had to deal with anything again. And what I don't want to be doing is supporting you, which of course we will do with all our effort, if it comes back and you're now looking at having to do something a lot more serious. Because once it gets out there and it gets into the bones or into the lymph nodes, it's an issue, as you can see from all these guys here. And that's why I feel, you look at this Amico paper, and they looked at a whole bunch of guys, and what they saw was the guys who had 4+3 and 3+4, and they had recurrence, they did fine on 6 months. But the guys who had the higher rates, more aggressive disease, the 8s and the 9s and the 10s, they did much better with metastatic free survival by going out longer. Now, did any of those guys want to stay on it? I guarantee none of them did. None of them. Because nobody wants to stay on it because it's bloody miserable. We know it. But but you can do it, but just recognize that that's the risk you're running, and that risk is supported. It's supported empirically. I'll find the name of that trial because I should have.
Rick, it's Radicals HD.
That's it. Thanks, Radicals. Thank you, Radicals HD. Thank you.
So Rick, let me ask you this: Are
Yeah.
you saying that if we monitor the PSA every 3 months, which is the plan,
Yeah.
if we monitor the PSA every 3 months and we all of a sudden see a change where the PSA is starting to go above, 0.1, and in other words, we catch it early and I go back on ADT, are you saying that I've missed the boat?
I don't know. I don't know. I don't want to be in the position where I'm worrying about that. That's really what I'm saying. I don't think anybody knows. I think that what they know is that the guys who stayed on for longer had better outcomes with 2 years than they did with 6 months if they had Gleason 8s or 9s originally.
Yeah.
That's what it says.
I understand. I get that. I totally understand that. And I do see it as a little bit of a risk, but the one thing that I see is I'm guaranteed, if I stay on this, I'm guaranteed what I'm already feeling and seeing, which is a deterioration of my body, which is just driving me crazy. And I feel like it's worth the risk for everything I know, which is not a lot. I feel like it's worth the risk.
Well, when you say you're guaranteed, I think what you're guaranteed is that you won't improve until you come off it. But I think you can mitigate the downside, and there's a lot of guys on here who have done that. You can mitigate how bad it gets. It won't get better, that's for sure, as long as you're on it. But how much worse it gets is really up to you.
Yeah.
And each of us has our own story about how much worse it got and when it got that much worse. But believe me, I mean, I was a Gleason 8, and I didn't want it. I was 56. I didn't want to be without testosterone for the next 30 months. But I did it, and thank God, knock on wood, I haven't had a problem since.
Yeah.
And I am convinced it was because, for me, I really believe it was because I did that. Now, I didn't do abiraterone or anything else. I might have today with my disease demographics, they probably would have added another drug if I presented today, but I didn't. But I don't know. I mean, there's people. We got 3 hands up, so I'm handing
Yeah,
it back to.
I got a few hands up. I'm going to ask Len a question first and then get to you 3 guys with hands up. Len, what you just posted here, how does a 72 versus 78% difference come out to a hazard ratio of only 0.77?
I
I'm not
was
very good at this statistics, but it doesn't.
neither am I, John, but to me, if you want to try 6 months versus 2 years, and the only
Yeah,
benefit is you get an extra, 6% chance at the end of 10 years of metastasis-free survival, I think it's certainly someone like Todd has every right to say, you know what, I'm okay with the 72% versus the 78% if I can avoid 18 months additional ADT.
yeah.
Uh, of course, these are medians, and he may react more positively or
I
less positively.
I don't think that's what it's. I don't think that's what it's saying, but maybe it
Seems
is.
to me that's pretty direct.
No,
70,
I think it's saying that you are 23% better off doing 2 years than doing 6 months. That's what I think it says. But
Let me
yeah,
ask. Let me ask a question of Rich Wasser. So he's got his hand up, and a lot of psychologists are well trained in analysis. So maybe he can tell us. This is an important point that we have to know. Rich, can you
I,
comment?
can you hear me?
Yes.
Okay. So yeah, I've been listening to this discussion, and managing the side effects of ADT is my bias. And I'm not, by the way, trained as a psychologist. Was a professor of anatomy and neurobiology, but drifted into it as a research area. We've talked about that.
Oh, sorry, Rich.
For this discussion, I can't stand the suppressed testosterone, the castrated state, presumption that one can't tolerate this. That turns out to be highly dependent on what patients know in advance about managing the side effects. So I think some of you may know this story, but I have been on hormonal therapy almost continuously for over 20 years. Okay? And I'm an academic and I published a ton of papers. I got so interested. This is the odd way of looking at it. I got so interested in this that I made it something of a career. And you may know this. We run a class here in Canada where I'm based. You can go to the website, just www.lifeonadt, where we run educational classes for free for patients who are going to be starting these drugs. And we've done the research to show that they're better off managing the side effects. So yes, they're miserable if you don't know what's going to happen to you. But if you know that you're going to have hot flashes, and here's what you can do about it, okay, and here's how effective they are, then all of a sudden the hot flashes become manageable. So for someone who's saying, I can't stand the ADT, I'm not going to, they're advising me to be on it for 2 years, I'm not going to do that. I don't recommend that. I do recommend looking at how to manage the side effects. And I've seen people training for triathlon on ADT. I've seen people have gained no weight on ADT. I've seen people who exercise furiously. I'm maybe one of them, and have no depression from ADT. It is manageable. But the facts are, that's basically the background of the science there is, it is absolutely true. If you're at high risk, the data show an advantage of extending the ADT past the 4 or 6 months up to the 2-year mark. And in fact, there's one paper, I don't have it in front of me, which actually gets it to because of the way they did the statistics, it wasn't exactly, 3 years or 2 years. It came to this number of months and weeks. So if they're giving you advise you, first ask yourself, what can you do to manage the ADT side effects? You can confer directly with me if you want. If they, check out the website. If that looks manageable, then I would follow the doctor's advice. John, did I answer your question?
Yes, thank you. Jim Marshall?
Yes. Anyway, I've been on a treatment holiday for 16 months. 5 5 years, essentially ADT, Zytiga, etc. And I get my testing done every month, a PSA test and the testosterone. I do not want to wait 3 months. I want to see that puppy every month. It's just me.
Okay, so Todd could talk his way into 2 months or even less if he's at all anxious about it.
I like that.
And it's nice to know, of course, going into this, that you're still very hormone sensitive. Gary Peters?
I was just going to ask Todd, where do you get your fenbendazole? Is it even approved for humans now?
No, not at all. And I don't think it's appropriate for me to like talk about it in this group. I mean, Rick, I would leave that up to you, but I don't want to be promoting anything because I'm certainly, not a doctor. I'm certainly not a whatever. It's something that's out there. It's for animals. It's not approved by the FDA for human beings. Menbendazole is, which is the same basic product. I mean, Rick, you don't want me talking about this, right?
Look, the way we we definitely support all complementary medicine. Alternative medicine, we do not. Somebody who was doing fenbendazole in place of everything else, we would not support. If you're doing fenbendazole in addition to your allopathic treatment and your doctors are aware of it, God bless you. We don't promote it, but if it works for you and you feel better doing it and it reduces your stress levels and your doctors are aware, we say that's fine. I would suggest Gary and Todd send Gary a note in the chat window, and the two of you can communicate. You can provide him the information. But
Yeah.
we don't recommend. We would not recommend fenbendazole as an alternative medicine. If it's complementary and it's not hurting you and your docs are aware of it, it's your decision.
Yep.
Okay, Todd, I knew that was going to be a lively one. That was a really good discussion.
Thank you very much.
got
I really appreciate it. And I'm listening to what you're saying, believe me.
You get away with this, I'll be very jealous.
I'll tell you what though, Todd, I'd love for you to send that paper to Dr. Guanciale and see what she says.
I'll be happy to.
Because we really respect her opinion.
I'll be happy to.
And this is a whole nother issue, and it's a very interesting issue to me. It's really right in Richard Wassersug's wheelhouse. Is, when patients walk in and they advocate for themselves, but they have a preference, which is to get off. How does that affect what the doctors say? And have you ever studied anything like that? You're muted right now, Richard. Unmute and tell us. Have you just?
What was one last thing? This may not be really what you're asking. I just thought of one more thing, going back to the core discussion. Yes, you can go on ADT and off it. Yes, this famous study showing that intermittent therapy is no worse than a non-inferiority test to continuous therapy. However, there's another way of looking at those data. It turns out ADT is always more effective the first time you use it. And it just may be that cycling on and off cuts the lengths of time of its effectiveness. So if one can tolerate being on it and you're recommended to stay on it, the case for staying on it may actually be effective longer in the long run. And that actually cycles back to what Rick was saying about progression-free survival. It may not extend your whole life, but it may slow down progression-free survival, which wasn't the endpoint in the comparative non-inferiority trial that looked at intermittent versus continuous therapy. In some, I think that's a whole other question you're going to ask, Todd. Is what are the things that I'm having a hard time tolerating, and what can I do to overcome them each one by one in terms of whatever symptom presentations they have. Because it's so easy to throw your hands up and say, I can't stand this medicine, I'm going to go off it, when it may be saving your life. All right, I should stop there. Did I answer your question? I don't know. Whoever
Rick,
asked.
that was your question?
Well, no, the question that I asked was a different one. The question I asked is, when a patient walks in with a bias, how does that affect what the doctor recommends?
Oh boy. All right. Well, I was, I guess, saying the same thing, but in a very, very indirect way. Um, it's it's a challenge for me, and I bet it is for Rick, and maybe for Lynn and a few others who are really somewhat experts here. To when I see the doctor, is to not offer any opinion or advice about what I should be doing, and let the doctor be the doctor first, because the biases will bias the doctors, and often they will want to please us patients. If they, in fact, and it can bias the doctors in many different ways. We walk into our urologist's office, and it's usually he says, "How are we doing?" And we say, "I'm fine." We feel miserable, but we just lied. We just biased the doctor. Okay. Alternatively, we walk into the doctor's office, and I'm taking this herbal mix, and I'm doing great. What do you think about it? As a doctor, you don't know what to think about it because it hasn't been approved. But what are you going to say? You don't want to offend the doctor. So if you say, well, I think that's okay, then you interpret it as, that sounds good. But it wasn't discussed in an honest and open way with normal information. Best thing to do is hold back. Notice that you can bias your doctor, and your doctor can be biased by you. And have there been studies on this? Yes, but don't ask me for the references. I did. Thank you.
That's a really great suggestion. It would make a great invitation for a group sometime if one of us wants to take that on. Steve Rue, I wanted to get your comment and then get to your whatever your issue was tonight after that, okay? Steve?
Oh, yeah, hi. I've missed a lot of meetings. I've been very busy trying to pick up some employment, helping adults with IDD issues, developmental disabilities. Been quite a lot of fun. Got a dog too, a rescue dog that was also apparently a developmental disability. But I've been going, after here, I picked probably the best night to actually jump in and come back and visit you guys. And I say that because I too am taking a holiday from my ADT, and I was glad to hear Rick say that somebody with my Gleason score would do better at 6 to 24 and not stopping before 6. I'm at 9 months, and I'm going to take a break, and I have had a discussion with my oncologist and other people. My issue is not the hot flashes. I don't really care about those or the migraines, but the fatigue is overwhelming. It's like walking into a 100-mile-an-hour wind on a daily basis. If I get up at 6:37 in the morning, I'm ready for a nap at 9:30. It's stupid. So I've been monitoring my blood work pretty well, and I had a discussion with them about why they keep telling me to take more iron when my iron levels are fine. I don't have an iron deficiency anemia. I've got something else going on with low red blood cells and enlarged red cells. So we had a talk and said, look, why don't we just take a 90-day break here and come back at this at the start of next year? So after 9 months of my Leuprolide, I said, hey, let's just put that syringe back in the box and I'll see you in January. So I postponed that October treatment. And I can tell you that I'm a strong believer in letting doctors do the doctoring and the plumbers do the plumbing, and all of that. But I also believe that I have to pay attention to what I'm feeling in my body and seeing in my blood work. And when some of the things don't add up, I need to go back to GP or to some other second opinion to say why is this happening. one of the first things I did do when I got him on the phone and we had a little conference call was I told him immediately I didn't want to be in the clinical trial anymore because part of that clinical trial required me to stop taking a lot of supplements and things that I was normally taking, like vitamin B and a high level of vitamin B in my system. I've always had, and if I've always felt like I just really did, really well when I had a higher level of the B complex. So that was one of the things of several I had to put back in the medicine cabinet and not take. And I'm not saying any of those things are contributing to what I'm feeling or what my blood work looks like today. I'm really certain that it's the Lupron. It's the culprit. Um, my PSA is undetectable. My testosterone is undetectable. And we're just going to look at it again in 90 days. I'll get, well, in January or whatever, I'll get another blood work done and we'll see where it sits. I like what Jim said, though. He's not waiting 90 days. He's doing monthly. So,
Yes.
Hey, I think before I take my road trip to Texas for Christmas, I think I might get the blood work done again and not wait till January. So, but we're gonna regroup, fall back, regroup, and look at it in late January and see what the blood work looks like and how things might be improving. But with the red blood cell count so low, with enlarged red blood cells, with some of the stuff I'm seeing off my CBC and blood work, I'm a little concerned about that. Uh, I'd like to address that before returning to the ADT. I'm not opposed to returning to it. I just feel like this is the best choice for me, and my doctors agreed with it. So that's where we are today. And surprise, surprise, I'm in here listening to Todd and everyone else talking about some of their holiday. And I know I understand what Rick is saying, and I fully understand that. Um, but I'm happy with my decision, and we'll see what we'll know more in January. Is all I'm saying. That's really all I got tonight.
What was your Gleason score?
9. It was
9. Yeah.
5.4.
Yeah.
It
Same
was
with
high.
me.
I'm high risk. Yeah. So,
Yeah.
I mean, I know that I should stay on it for 24 months. On the other hand, I don't think taking a 90-day break and then taking a look at my blood work and see if we can get some improvements there would be that detrimental to, my PSA scores. I could be wrong. It's it's worth
Oh,
it to
no.
take a breather and see what we can do with the blood work instead. Focus on that. Put the focus on that. All that, everything they're telling me to take more iron and exercise more. I exercise. I work out. I shovel a lot of snow here in Michigan, especially this time of year. I've got, I can't tell you how much iron I'm taking. Supplements. It's insane. And that has its own effects too, as you probably all are aware of when you're trying to sit on the commode and things aren't coming
Yeah.
out right anymore.
Yeah. Yeah. Have you
So
seen a hematologist, Steve?
I have not seen a hematologist. That was discussed by my PCP, and that is something that we're lining up, getting that
I
aligned to
think
do
it's a
that.
kind of a good idea because I also was taught, like you, that um, if you have good iron levels, that you're not going to gain anything more by adding iron except for stressing your liver a little bit. I was taught that big, enlarged red blood cells in the context of anemia, that you look more toward vitamin B12, folate, alcoholism, things like that, rather than iron. And so I would get levels of those two things. And if you want to get an expert opinion about all this iron, I would say see a hematologist, and that should trump everybody. Len?
Sorry, were you calling me, John?
Yeah, I thought you were about to say something because your panel lit up on my
Oh,
screen. No?
no, no,
Okay.
no. I agree with what you're saying, but I didn't have anything original to contribute.
Okay. Jim Marshall, you have something to contribute, right?
Yes, for Todd, do you have a schedule for the prednisone withdrawal yet?
Todd, that was for you.
What was that?
Do you have some kind of schedule for the prednisone withdrawal? Okay,
Cold turkey.
no. Well, okay. I would say I think we had a big discussion a couple of weeks ago here, and so cold turkey was thought not to be such a good idea.
I think that would be a, what are you on, 5 milligrams prednisone?
Prednisone is 5 milligrams.
Yeah,
Okay, uh,
I'm with Jim about that. I'd go down to
Yeah,
2.5.
and I meant to raise it and it slipped my mind, so thank you. And I'm really sorry to Steve Rue that we just jumped into your thread, but this is so important. And somebody should have said something on that one, Todd. One of these
Yeah.
docs. I mean, don't, for goodness sake, don't go cold turkey. You'll be coming back to us next week and telling us how you're feeling awful. And then 2 weeks after that, you're losing weight and you've got to come off slowly.
Yeah, this is totally new to me. So tell me what's going on. Like, what should I do?
Hey, well,
Well,
you
I mean, what I would
hopefully
say
the,
you do is reach out. I mean, whoever the doctor was that said to you it's okay to come off your hormone therapy, go back to them and come off the abiraterone. I would go back to them and say, you didn't mention tapering the prednisone, and I've been on prednisone for 7 months. What do you recommend?
Okay.
Come back and talk to us about it. And I would say whatever they recommend, I would, if it were me, I'd extend it by at least a third, if not, double it. I mean, because some of these docs tell you to get off in 2 weeks, and that's when we see the problems. I mean, who's come, Peter? Anybody who's come off prednisone, speak up, please.
Yeah,
okay,
I just finished a wild ride for a month and it was terrible. And I mean, I had all kinds of problems going on, and and you just got to do it. I thought I was on. My doctor put me on a weaning schedule, but it wasn't effective.
I stopped in
Jim,
July and I weaned off for about 2.5 weeks, but I had a lot of fatigue in the afternoon for about another month and had to go to sleep. I just could not stay awake. So that's another one. That's one of the symptoms.
This is new to
um,
me.
uh, the thing I did, looking back, I believe I did the 2.5 for 14 days. I did the 2.5 essentially every other day for 14 days. And then I did the 2.5 essentially every third day for the 14 years. I was on it for 5 years. So I stretched it out.
yeah, give it at least 3 weeks. Yeah, 2.5 and every other. Even if the doc tells you to just go off it, because the argument is you've been on it, quote unquote, only 6 months, but our collective experience is that you should take at least several weeks to get off of it.
And do 2.5 per day for 2 or 3 weeks.
Well, maybe 2 weeks, maybe. I
And
mean,
then every
for
other day.
me, I did it pretty fast, but for most of the guys, based on most of the guys' experience in this group, I think you should go two. If you want to be conservative, 2.5 for 2 weeks, and then every other day for 2 weeks, and then off.
Okay. All right.
Or maybe even another step like Jim did. Um,
It's
There was a
Muslin. I've got one question. It's Muslin, and it's for Todd and for
David.
the rest of us. And yeah, I hope you guys can hear me. Um, I was on abiraterone and Lupron and for 2 years, and then what I did, and I really followed Len's lead on this, is I then went to monotherapy Dara, and it was a huge. I felt so much better on Dara, and I didn't have the bad side effects other than hot flashes. And then after being on Dara for a year and a half, I then decided to take a holiday. So is it more of a conservative approach to switch to Dara rather than getting off cold turkey, Todd? I
So
mean,
I'm
I
not
know it's
familiar.
all
I'm not familiar with Dara.
daralutamide.
Daralutamide. Yeah,
The
that never came up with the doctors.
He's on
yeah.
abiraterone, yeah.
Right, but I switched. I got off of Abby and I got off of the shots after 2 years, and then I went on daralutamide, and for me it was a good thing, and my PSA stayed undetectable, and I just got off of it after being on it for 2 years, and I'm just watching it now. But for me, it's a lot safer. For me, it feels like a lot safer than just dropping it right now after 7 months with a 9 Gleason.
I
That's my only input to you, my friend.
Yeah.
I am surprised that neither one of the doctors brought that up. I can
Yeah,
certainly go back and ask them about it.
hate to say this to you, but that's what Shmulowitz recommended for me.
Okay.
Yeah, and again, I mean, I think that's a discussion. I mean, the guy at MD Anderson is pretty young. He's not long, he hasn't been practicing that long. I think Dr. Guanciale has definitely been practicing a lot longer, and she's certainly familiar with darolutamide as monotherapy because Len sees her, and Len's been on and off darolutamide monotherapy probably longer than anybody in the whole country, I would say. Um, so it's worth a discussion with her. I mean,
Yeah.
I really like what David is saying.
I'm,
um
I'm going to reach back out to both doctors and see what they have to say about it.
yeah, I mean, darolutamide monotherapy for a while, and definitely I mean, I would almost guarantee that Dr. Guanciale probably thought that Dr. Hahn had talked to you about tapering on the prednisone, and so she didn't go there. But if you ask her about tapering on pred, she'll, I bet she's fairly conservative too.
Yeah.
You got to be. I mean, I had a buddy who went cold turkey. He lost 35 pounds, and nobody ever. And his doctor was one. I won't name the doctor, but everybody in this room probably knows who he is, and he's one of the most prominent GU medical oncologists. He forgot to mention it. His nurse practitioner forgot to mention it. My buddy Dick, God rest his soul, was miserable. Couldn't figure it out. And then then eventually he realized he'd gone cold turkey and nobody had told him to do that. Now he'd been on Abby longer. He'd been on Abby longer than the 7 months, but you got to be really, really careful with that, coming off of that prednisone. Super careful.
Okay. Well, I'm really glad that this is nobody mentioned any of this to me, so thank you all.
That's what we do.
That's what we
I love
do.
it.
Steve Rue, before I move on, Steve, did we finish with you?
I had a
No,
question for Steve
Yeah,
Rue.
I
there he
just
comes.
wanted, yeah, I'm done saying what I was going to say about that. Like I said, taking the iron and all the other things they kept telling me to do to try to help the anemia issues I'm having, none of it helped. So
Rick has a
I think the
question for
be,
you, Steve.
best advice I heard was see that hematologist that we talked about.
Yeah, I mean, the hematologist is a great idea. And you, at one point, we suggested you speak to Elizabeth Heath at Carmenos. Did you ever follow through with that?
No, I did not.
Okay. And again, definitely, I mean, she's terrific, and love to see. We'd love to see her on your team, because as I recall, you don't really have a GU medical oncologist on your team right now.
No, I don't. What could you tell me what that name again is? Her affiliation?
Her name is Elizabeth Heath, Heath. I'll put it in the chat window. And
She's out.
her affiliation is with Carmenos, which is, I know you're a UP person, but she's in Carmenos is in the Detroit area, and she's really, really good. And
All
I
right.
can Elizabeth Heath, I can't spell today. Carmenos, I think that's it. Carmenos, yes, it's there, and I'll put a link to her profile for you in there too.
Okay.
Steve,
Thank you. Thank you.
how low does your hemoglobin sit? Where's your hemoglobin? Below 10?
Well, my RBC is 4.1. I'm looking for the hemoglobin right now. Hemoglobin is 13.
Oh, you're pretty darn good. My
Yeah.
hemoglobin's been between 9 and 10 for 9 years. And it's
Jeez.
not iron deficiency. I just have pretty low. I mean, I've learned to live with it.
Yeah, mine's never been that low in my life though. That's a
Yeah,
new low for me.
I know, but 13 is not bad. That's the so-called low threshold. I mean, it can go a
Probably
lot
the
lower than
best in the
that.
room.
The reference range they gave me was 13.2 to 16. So I
Right.
felt like, yeah, it's a
Yeah.
little bit lower. But as I said, some of the other oddball things are the RB. The white blood cell has been finally coming back up after the all of the radiation, but now the RBC is starting to drop, and that wasn't that way originally. So
Mine sits around 3.5, and it's been that way for years, and I can't budge it.
well, yeah, the
So,
RDW is down, MCH is down, MCHC is down.
right.
There's a lot. There's too much stuff here that's down that I need to have somebody look at.
Okay. Yeah, do that.
But the protein is just like, I don't get it. The protein's okay, iron's okay. The iron binding cap is high, but the ferritin's fine too. So what the hell's going on there? If the
Well,
binding cap was high,
treatment and drugs take a toll on your blood work. I mean,
yeah.
it's just I've had to live with it.
I think I think a couple of things. Dr. John's advice to involve a hematologist is solid, although you've got to be really careful that they don't just say, "Oh, well, you've been on hormone therapy, so that's it."
Yeah.
So, make sure you advocate for
Hey,
yourself and say, because it's an easy cop out for them to just put it on hormone therapy. And I'd love to see you have somebody like Dr. Heath on your team, because she would be all over something like this, and you could really rely, and she's seen enough men on hormone therapy to know what's hormone therapy, what's down to hormone therapy, and what's down to something else.
Would she be able to do like a teledoc kind of a thing, or would it be? Would you
I,
happen to know?
I
they
think you'd
would
have to.
probably that. Oh, I'm sorry, Rick, but I'll speak for the doc. They will be reluctant because they've never met you before. But it's possible that if you have enough lab work already done, they may be willing to talk to you. Um, you got to watch out that they also, besides what Rick said, oh, he's just on hormone therapy, they may say your numbers are pretty much normal, don't bother me. The reason that I recommended it was because you got other doctors treating you for iron deficiency anemia, possibly unnecessarily, and we need another doctor to argue against them. Whether they'll talk to you on the phone or not, I is up to each individual doctor. But before you even ask the question, send in all your blood work.
Well, I can do that pretty easily. I can give them full access to everything through months and all my stuff off my portal. Easy peasy.
Okay,
Rick, I'm
so
sorry to interrupt, but you were saying something too.
all I was going to say is I can't. John gave you a more comprehensive answer. I don't know what Carmenos's policy is, but you're within Michigan. She may be willing to see you on a because you're in Michigan. Some of these doctors say no. The first time we've got to see you in person, and then we'll come in and do virtual appointments after that. I don't know, but if you click on that link, it'll open up in your portal, and you can go from there. But she's really solid. She's a genitourinary medical oncologist. She's not a hematologist. But I think she would be my first stop, and then ask her, do you think I need to see a heme or not? That's I mean, that's navigation. That's not medical advice. I mean, that's how I would do it.
Okay.
Oncologists have a fair amount of training in hematology anyway. Rich Wassersug, you had a comment.
I just add to that as well. I've learned, and I've been reasonably lucky, that I've had good email and video and phone call conversations with my doctors. And there's some basic things that make it happen. If you want to hope to get into a email conversation with no visits and no anybody having to pay for anything, keep your questions a yes or no. Should I stop taking my iron? I mean, then they can answer it yes or no, and it's easier for them and you. So that's certainly a starting point that I would recommend. I'm up in Canada, and what doctors you can see by video and which ones you can't, and how it's funded. It varies from province and so forth. So I can't give you specific guidelines along those lines. But if somebody does say, following up on what John said, please send me your blood work. Given what you've alluded to in terms of taking a whole bunch of supplements, it really can help the physician by letting them know not just what the blood work shows, but every single drug and supplement that you're on. Because if you're on enough combinations, it could very well be hemotoxic, for instance. That could be accounting in some ways for the anemia. But if the doctors don't have that information, they can't give you an informed advice. I'll stop there.
That's a great point. And hematologists do rely a lot on labs more than a physical exam, so maybe it'll work. There's only a few minutes left. There were at least a half a dozen people, actually more like 9, that came in after I went from person to person and see who had anything to talk about. Do any of you guys that we haven't talked to have anything that you want to bring up in the last few minutes? Anything kind of pressing that you need to know this week? Rich K, Jerry Pelfrey, Len, Cliff, Larry, Dave, Jim, Gaushan, Neil. Everybody good? Okay.
Oh,
Jim B.
Jim B. Barnes,
Hi,
yeah.
hi guys. Thank you. Um, yeah, I was just, yeah, I got here late, but I'm just an update on my situation. I've been through all the standard of care treatments, all the way up through, 6 rounds of lutetium, which I stopped in August, and now it's, PSA's rising. And trying to figure out what to do. My GU oncologist has recommended a clinical trial for me that involves Xofigo and a PARP inhibitor. I'll 100% get the Xofigo, but it's up in the air whether or not you get the PARP inhibitor. But you know up front. But I'm just kind of looking at different options out there. I guess the only option that was presented to me really was cabazitaxel. So it was either go on chemotherapy or try this clinical trial. So for those of you who are still on ADT and it's working for you, count your blessings. I would love to just be on ADT at this point, because right now I'm at a point where it's like, what do I do? What do I do now? What's left? So I just wanted to throw it out there. I'm going for a bone biopsy last week, and I went for a bone scan on this past Friday just on the 24th, and my bone scan is showing significant disease progression with new lesions in my ribs, with the new lesions in my skull as well. So I've gotten some very not so happy news in the last couple of days. Just trying to figure out where to go. And any comments you guys have would be welcome. And if that stumps you, because sure as hell stumping me.
So my first question is, did you address getting a new sequencing?
Yeah, I mean, one meeting we talked about the FDG scan, another meeting we talked about the sequencing. And my doctor's issue with the sequencing is he's like, there are so many tests, so many rabbit holes you can go down with too few actionable results. And that's his position. And I know what you're going to say, Rick. It ticks you off. And where the hell's precision medicine and personalized medicine and all that? So, but he's not against doing it. It's just it's not something he's being proactive on that side of. And if I go in and I'm demanding it, who am I telling him? What blood work am I telling him to go get? What biomarkers are we looking for? When I said there's got to be other biomarkers out there, he said the best biomarker is the PSA. But then here I am 2 weeks later, my PSA's gone from 3 to 38 in 3 months.
Okay, so my position is this. If you don't have the information, you don't know. And if there's something going on with you and you have, let's just say that all of a sudden you now show a BRCA2. A PARP inhibitor might be perfect for you. But he can sit there and say, you're not suitable for a PARP inhibitor, or get it in the trial. That would be interesting. But if you have that marker, then we know that's the right drug. The same thing goes with if you have a very high tumor mutation burden and you're microsatellite high, you might be a great candidate for Keytruda. I mean, for him to say, well, the best marker, I mean, he seems like a pretty smart guy. I met him earlier this year. But you've got to get sequenced, Jim. No ifs, ands, or buts. And a liquid biopsy is perfect. I mean, now one of the things we know from the liquid biopsy is that it gives you a better result from everything that's going on in your body as opposed to something single. So the first thing is, and this is what I would be talking to about first thing in the morning. Number one, I need a liquid biopsy. I want it. Number two, I'd be looking for neuroendocrine small cell disease in your case right now. What are the markers? What can you look at that might indicate that I'm a good candidate for a platinum or some other type of treatment for neuroendocrine disease? Maybe this what's it called, Len? The one they're doing the trials on in San Francisco and elsewhere.
You mean that the BioXcel product?
Yes, the BioXcel. That's it.
Yeah.
There are drugs out there, but we've got to find out what's going on in your body, and we can't. And sticking you into a trial and watching your PSA ain't going to do it. And if Appleman ain't willing to do it, we've got to get you to somebody who is willing to do that.
That's where my head's going. Absolutely.
I mean, if he thinks it's not going to make a difference, then let's get you over. let's get you over to, maybe Narayan or Narayan at UPenn or Geinesman at Fox Chase,
Yeah,
or go to Chicago and go see Shmulewitz. But you can't just be sitting there waiting for things to happen, because it ain't going to resolve itself. And sticking you in a trial with Xofigo isn't I doubt that's the answer. We need more information right now.
I agree.
I mean, I get really, and I got agitated on this at the end of the last meeting. When men progress like this, we've got to be looking for these neuroendocrine small cell leads, because we don't have a lot of time to act on them. And now's the time to be looking at them. I mean, I'd love to get you out to Rahul Agarwal in San Francisco right now, because that's or to Misha Beltran at Dana-Farber. And where they know how to look for it. I mean, there's this DLL3 test, but it's not commercially available. Those guys know how to do those tests, and Appleman's sitting on his hands.
Is that a small cell neuroendocrine test?
DLL3 is, but it's not a commercially available. It's only available in the lab. Right, Len?
Yeah, as far as I know. But there are other biomarkers that a liquid biopsy could pick up, like the chromogranin A, and forget the name of the other
neuroanalase that Jack had brought up, and the ALP and all those things, right?
Yeah.
It could well be time, Jim. It could well be time for you to get a second opinion. And if you want to call me or Len or John, and we can, and we can bend some arms to get you in somewhere. Go down and see Dr. E. Another alternative. But we got to get you somewhere quickly, because I mean, for Appleman to not even agree that you should get tested, and you haven't been sequenced in 3 years. I mean, it's crazy. Because it might lead to too much information, and what are we going to do with that information anyway? Hello?
Well, it was less actionable information, but your point's well taken.
Yeah, Rick will every suggestion that Rick made that could be found, he followed by an action that would be appropriate for that result. That's what your doc wants to see. If this, then you could do this. If this, then you could do this. If this, there were three things that could result in an action. Yes.
I mean,
Jim,
there's a bunch of actionable.
Jim, it's David Muslin. You and I kind of know each other. We got close personally. Knowing who you are, I'd jump on a plane and go see Dr. E, because she'll communicate. She's a great communicator. I think that would be a really good move to get a second opinion. And I'm with Rick. You got to do it right now. Hope you heard all that.
He's still in Texas, right, Dave?
I did hear all that, David. I'm processing it. Yes, I agree with you.
Yeah. And we're here for you in a big way.
Yeah, we really are, Jim.
Whatever it takes.
Whatever it takes, exactly. Jim, are you in Pittsburgh, or are you in Florida?
I'm in Pittsburgh. I'll be in Florida in a couple weeks.
Well, then if you're going to be in Florida so soon, go a little bit early and stop off in Houston on the way. And I'll write to her and say to her, you got to see Jim as soon as you can. but if that's what you want to do, if not, get on a plane, go see Shmulewitz. Go see Shmulewitz this week, or David will call Shmulewitz, and we'll get you into Shmulewitz. Or or if you'd rather go to Philly, we can pull some strings for you in Philly. But we got to get. I'm really upset with Appleman that he doesn't get that there's a bunch of things that do work. And maybe they won't work for you because maybe you don't have those markers, but we don't know if you have the markers now or not. We just don't know.
Right.
I think Jim is
Peter,
convinced. I think Jim is convinced, and Jim, just call Rick when you're ready to see somebody, okay?
I was just going to ask if I can call you tomorrow, Rick.
sure.
If
Peter, you want to say? I think you might want to say something.
No, I think I totally agree with the conversation. I mean, I had a buddy here today, a neighbor, who is panicking about his small bump in PSA, and I told him just relax, and UCSF told him if he wants to see a doc there, he needs to come over first. And I said, well, I'd wait, and he said to me, Peter, you're not a doctor. I'm going to get on a plane and go to San Francisco. I want to see these people. I don't want to let this thing run away on me. And I said, boy, that's great attitude. You're right. Take care of yourself, Jim. This is your life. Do whatever you can. This is your life.
Okay, guys, barring any last comments, I'm going to close her up. Anything last minute comments? I enjoyed this group very much. A lot of great discussions, and I'll see you guys all
Yeah, and
next week.
Jim, make sure you download the chat, the three little dots, because Len's just put in a couple of things that you should see. I don't know if you saw
I
them
know.
yet.
Yep, I know. I see them now, and I know exactly where to find them in my downloads.
Okay, but it doesn't download automatically anymore. So now
Oh,
you got to make.
oh, good. Then, good.
Okay, so those three little dots, it says download chat messages, and then you'll go and find them there later because they stopped doing the automatic stuff.
It looks like all I had to do was flip a switch at the top of the the chat there, and it automatically download chat messages, and I clicked it on.
Okay, as long as you know.
Okay,
And
no, I would have missed
I
it.
want to know, is Muslin like is he at the North Pole? What's going? You got a Muslin? You saving money? You got no heat on in the house? What's going on?
I'm in Charlotte, and I'm just always cold, and I have long underwear on, but we don't want to get too personal.
First one of the year.
It's cold in Chicago, man. It was 15 degrees this morning. And I'm here
Wow.
Oh,
now. It's
where
going to
are?
be. And now I'm in Charlotte.
Oh, you're in
But
Charlotte.
yeah, and by the way, I was able to join on the group up in the airplane. It was crazy. I never could do that before.
Oh my gosh.
Wow.
And I got
Oh
off
my
the
gosh.
plane, Ubered here, and I stayed on the line the whole time. So that was pretty cool. Hi, Todd.
I bet your seatmate liked that.
Whatever. I have my headphones on. I keep my mouth shut. I just listen.
Well, David, I know that your boat is in Florida, so why the heck are you not down there?
Oh, because I got in trouble with Jimmy here a little bit. We bought a piece of property in Charlotte, so I got to be here tomorrow. Can't help myself. All right, you guys. That was a great meeting. It was really
Yeah,
a
thank you all.
very good
Good
meeting.
night,
Pleasure.
everyone.
And I'm
Thank
going to
you.
call you.
Thank
Tomorrow.
you,
I'm going to
Thank
call you
you for
tomorrow, Todd.
presenting.
All right, thanks,
Okay.
Dave.
Bye.
Bye.
Hey, Rick. Shit. Len, I don't have Rick's phone number.
Oh, you need Rick's phone number?
Yeah. Grabbing paper and pencil here. I'm
Oh,
ready.
okay, hold on. I got to look it up. Let's see. Hmm. Okay, you ready, Jim?
I am.
All right, 415-505-0924.
Perfect. Thank you so much.
Okay, good luck, Jim.
Thanks, man. See you
Hey,
guys.
listen, Jim, did you say you have bone only metastases?
That is correct. That is
Yeah,
correct.
so I mean, I have to disagree with Rick a little bit there.
It
Uh,
ain't out, it isn't out of left field, you know. So
yeah, I mean, Zofigo is perfect for someone like you. I mean,
that's what he thought. And he said he's like, don't. He's like, it's not going to lower the PSA. He's like, we gotta focus on not, you know, depending so much on the PSA. We're going to watch the tumors. We're going to see what the Zofigo does to the size of the tumors. That's what he's really.
yeah,
That was his explanation of his strategy to try to control it.
yeah,
But it's scary.
because Rick's talking
Scary.
about,
It's scary because am I just letting it go sky high? You know.
yeah, I think what Rick's focusing on is neuroendocrine small cell cancer, which I mean, it's possible you have it, but it's more likely you don't.
It's kind of rare, isn't it?
It's well, yeah, like someone who's been through a lot of treatment like you, the rate is still about maybe.
Are we still being recorded, by the way?
Oh, no, I don't think so.
Okay, just good.
Uh,
Not that I care, just good to know.
no, we're not being recorded.
Okay.
Um, something like 15%. So I don't know if you consider that rare. It's uncommon, let's put it that way.
15% of what?
15% of patients with metastatic castration-resistant prostate cancer
End up neuroendocrine.
Yeah.
Okay.
So that means 85% do not have it.
Right. Yeah, but 15% is not small to me. You know,
Not small, no, but isn't. I mean, it's certainly worth investigating. Get that liquid biopsy, find it. Get those biomarkers. See if you have those biomarkers.
Yeah. To be honest with you, I am in I've started dialogue with a a doctor in Austria, in Vienna,
Uh,
to potentially get actinium treatments.
yeah.
I watched the recording last week of the AnCan video, and you gave a little explanation about actinium. It was a pretty good explanation that you give the alpha emitters versus the beta emitters, and shorter and further and stronger. And so
Right.
anyway, that's one of the things I'm
But
considering.
here's the thing, Jim. Both lutetium, which you've already had, right?
Right. Yes.
And the actinium, they both don't work unless you've got the PSMA protein. I don't know if you do or you don't.
Yes, I had PSMA avidity, 100%. Yeah, I mean not 100%, but I mean 100%. I did have PSA avidity,
Okay.
PSMA avidity.
Yeah. Okay, good.
So anyway, I'm starting to talk. I have not had a communication with this guy except via email. I actually got him all my medical records and everything else, and learned a lot about our hospital system doing that, trying to get that done. But so I'm kind of pursuing that path. But I don't like to bring that stuff up on a call because I don't know if that's controversial or not. You know what I mean? So I would never mention
Oh, no, I
activity.
don't. No, that's not controversial at all.
Okay. I kind of like AnCan because it's like it's all pretty much standard of care, super proven technology, or treatments, and I like sticking to that. It's all, if people are bringing in this miracle cure of a dandelion wine or something, or that, you know what I mean, it can get out of hand pretty quick, and you guys keep a good governor on the whole conversation to an appropriate level, I think. So you guys doing a good job. You got a good platform here.
Well, all right. Good luck to you, Jim. And, give Rick a call.
All right. You're in Florida now?
Yeah. Where are you going to go in Florida?
I'll be in Marco again.
Where is it?
In Marco Island. Same.
Oh, yeah, that's right.
Same condo and everything. Me and Peter hooked up there last year for lunch a couple times. Now we're talking about playing golf. So
yeah, I remember. Yeah. Then he works his way up to Anna Maria Island, and he stops to see me because I'm in Venice.
Right.
Yeah. And also sometimes, maybe we can get Bill Franklin to join us. Well, anyway, I got to go, Jim. Good chatting with you.
Thanks for the
Good
extra
luck.
time. Let's see it.